Welcome to the Interventional Glaucoma podcast, brought to you by Elios Vision. Join us for unscripted discussions about the latest innovations in interventional glaucoma with leading ophthalmologists in the field. In this episode of the Interventional Glaucoma podcast, Dr. Ahmed and Professor Gazzard kick off this series with a discussion about the interventional glaucoma mindset and how it is changing the course of glaucoma treatments for the better. Let's listen in.
Well, welcome everybody to our very first episode of Interventional Glaucoma, our podcast series. I'm excited to be here. I am your host today, Ahmed, from Toronto and from Salt Lake City, Utah. And I am very pleased to be joined by my colleague and good friend, Professor Gazzard from London, from Moorfields. He's a colleague and is a household name in glaucoma. Really excited to do this series with you, Gus. I know that there's a lot of things happening in the glaucoma world, and you've been in the center of it. So thank you for being my partner in this very first podcast.
Well, thank you. I'm looking forward to it. I think it's going to be a lot of interesting discussion. I think we're going to get some really interesting topics to go through with all of this. And as you say, it's a very fast-moving field. I think there are a lot of new developments on the horizon, a lot of interesting toys, gadgets, devices, and a lot of things that we're going to be offering our patients over the next few years that's going to make it continue to make it a really exciting field to be in. So I'm looking forward to the podcast.
Yeah, I think it's great. I think it's a great time. And I think it's also, creates a lot of uncertainty and questions. And we hope to try to address these, maybe address some of the different myths, misconceptions, talk about what evidence there is and what we still need, and perhaps give some guidance to our colleagues and to ourselves about where we need to go. So thank you for joining us here. And I thought we'd just start off a little bit talking about interventional glaucoma. We're in kind of this age of buzzwords. Everyone's into these, acronyms and terminologies. And I think lately we've seen interventional glaucoma being used. It's not as popular as Instagram, but it's got the same acronym, IG. And, I'm curious about your thoughts, but, when I think about interventional glaucoma, I think about, typically procedural related approaches to treating glaucoma, primarily lowering IOP, that are done in ways to address some of the shortcomings we have currently with which of course are with drops and adherence. And they're meant to really try to address things in a more definitive way, perhaps ideally approaching things in more physiologic and safer ways that can be adopted earlier in treatment. And, thereby, using things that maybe we haven't conventionally been thinking about. And I think as opposed to a certain technology, I kind of think about interventional glaucoma as more of a mindset or approach in terms of thinking, is now the time to intervene for my patient, wherever they are in that journey, whether it's primary initial diagnosis to refractory glaucoma to cataract surgery. And so I think that we've been blessed these days to have technologies that are emerging. And I think that's kind of where I think the mindset is in terms of thinking about this. Of course, this is an idea. It's an hypothesis. It doesn't require necessarily any major evidence, but more of an idea that we have to build around. So that's kind of what I've thought about interventional glaucoma. And I'm curious what you think. What we think about when we think about intervening in glaucoma in 2024.
Yeah, I think the terminology is something that has, as you say, it's a buzzword. And the danger with buzzwords is that people kind of sit beside them, hide behind them, don't think through what it means to them. And it means something slightly different to everyone. But I think I pretty much would agree with the idea that it's a shift from the traditional. It's a shift away from where we were maybe 10, maybe even 20 years ago, where you had glaucoma, you got a diagnosis, you were put on a lifetime of drops, and surgery was a last resort for when that failed. And we know that there are huge shortcomings of that approach for our glaucoma patients, with adherence, with side effects, with all those problems of medication that we're very familiar with as glaucoma specialists. And now that we have a whole range of opportunities and alternatives and various forms of interventions, that we've clearly shifted towards a slightly different approach to that individual patient's journey. Before it was very simple, meds and then surgery as a last resort. Now we've shifted the dial to being able to, as you say, intervene, do something earlier. And it's IG, or interventional glaucoma as I see it, is a shift towards a change in mindset to get in there and hopefully be able to just change the disease course and, derail that inevitable train crash towards surgery, and actually say, right, if we can intervene very early, maybe we can do something physiological, as you say, maybe we can do something at an earlier stage that will get us on a better track, that will get that patient under control, maybe for many, many years to come, with much less to do. And whether that's laser at the beginning rather than medications, whether that's a laser at the time of surgery to lower pressure, or whether that's less invasive, more minimally invasive procedures even after cataract surgery, it's that shift towards something, as you say, interventional. But including, in my mind, with that, we're including slow release, injectables, and all those other things that are really on the horizon for us.
Yeah, I totally agree. I think that's it's always important to think about the why, and I think you've touched about it as well in terms of why do we need this? And I think it's changing from a passive mentality to a more active mentality, and to address the shortcomings of compliance, adherence, important quality of life issues that our patients face every day with treatment. And I think what's very interesting, what I'm also excited about, we're going to address this in the next few podcasts, which we have an opportunity to potentially even alter things on a histopathological level to change the course of the progression of disease, which again points to the need to think about dealing with things early before things become, permanently and irreversibly changed. So I think some of the clinical, theoretical, histopathological, and rational about why we need a new approach and why interventional glaucoma is a different mindset, and why as you said, we've mentioned a number of different technologies that I think can empower us to do that. One area, Gus, maybe we can jump into is how interventional glaucoma is connected to cataract surgery. It seems to be an entry point for some to think about doing something, because it's in some ways it's, I guess, convenient in that we're already in the eye, but there's, I know, many other reasons. So maybe reflect a bit on your thoughts about how this mindset is connected to cataract surgery.
I think it's certainly not the whole of the why and wherefore of interventional glaucoma as a mindset, because as we touched upon, I think it's starting earlier than that, with the very primary diagnosis and first treatment, and the idea that you can potentially, with some lasers, change physiology, rescue trabecular meshwork, rescue function for at least a period of time. But I think the joy of procedures which are combined with cataract surgeries, as you say, you're in the eye already, you're there already, they've already been exposed to, the patient has already been exposed to the risk and potentially the cost, but also the small risks of opening the eye and being there to remove the cataract. And then you've got that opportunity, you've got that window of opportunity where you can do something else in addition to the cataract extraction that gets you some of those benefits of an interventional procedure, above and beyond just taking out a cataract and putting them back on the same old drops again. And for me, it's making surgeons think slightly differently and understand that every cataract extraction in a glaucoma patient that doesn't have some additional procedure is a missed opportunity. Now, let's put aside cost effectiveness and the barriers to providing that opportunity to everyone. But any patient who's having cataract extraction, who is taking medications, should, I think, be at least discussing and thinking about and offered some additional interventional procedure, because then you've got that window of opportunity to give them some extra benefit. And I think that's a route into the interventional mindset, because you can say, well, look, you've got this whole additional benefit for very small additional risk, and often a small additional cost as well. So then once you've done that, then you can start to look at other cost benefit balances and ratios for other forms of intervention, either pre or post cataract or alongside it another time. But that moment of cataract is it's a golden moment. It's a golden opportunity to be there. That cataract extraction is the time when then it's a clear win-win for both, for a small interventional procedure to give them some long-term benefit.
Yeah, and you're right, Gus. I do think interventional glaucoma certainly is much beyond that, and much beyond cataract surgery. But it is a good entry point. It is a good entry point, and I think, as you said, it's an opportunity, and it's a potentially a lost opportunity if we do miss it. If we think about some of the statistics on cataract and glaucoma surgery, figures point to anywhere from 10 to up to 20% of patients who go to cataract surgery are either on glaucoma drops or have a diagnosis of glaucoma. And so it's a fairly large segment that potentially could at least be considered for these approaches. We also know statistics show that, worldwide, that the number of patients who actually have some form of intervention at the time of cataract surgery for glaucoma is very small. It's probably, depending on where we go, it's anywhere from a few percent to 20, 30%. So there certainly seems to be a gap between that, but things are changing, and things are changing in terms of this attitude. Where do you feel the gaps are in terms of this? I mean, you've mentioned the rationale for interventional glaucoma, some of the potential benefits, and some of the rationale. But what do you think we need to do in terms of taking this further, in terms of thinking about how Phaco Plus is evolving, and why and how we move to the next step in terms of broader acceptance?
Well, every time we talk about this, the thing I always bang on about is I want to see some evidence. I want to see the trials. Let's get the trial, RCT, randomized controlled trials out there justifying the use of a device or a particular procedure or a particular laser, so that we can sit there in front of our patients and say, yeah, we've got some really good evidence. This is not just because it's going to be good for the bank balance. This is not just because it's kind of fun to do and it's the latest thing on the block. This is something we can really stand behind and say, this gives you good benefit. And you and I know that there's now great RCT evidence that MIGS in the broadest sense, and there are some good specific examples from long-term RCTs showing good data that MIGS can get people off medications for many years. They can even be shown to preserve visual fields for many years, particularly in rapidly progressing at-risk patients that we worry about most. So I think one of the barriers is that there's a concern around some MIGS that we don't have that evidence. There are implantable devices where that evidence has been gathered already. There are devices and procedures and lasers and laser ablation procedures where that evidence is being gathered as we go along. But I think one of the hurdles is being able to stand in front of skeptics and say, look, here's the evidence. This is what we can show you. There is also, and I think we have to be open and honest about this, there is also always an issue around cost, because drops are and can be cheap, even if they are not ideal and they cause side effects and people don't like them. And so I think in order to be able to ask cash-strapped health economies to invest in these procedures, we need those trial data to really say, no, we've got to do this because it's the best thing for the patient. So let's get on and do it. I think in terms of barriers as a profession, I think a lot of us we're busy and there's inertia, and some people are very early adopters. I mean, you're out there defining what we're going to be adopting in a year or 5 or 10. But I think a lot of people are conservative, and I think a lot of people need that push, need to be shown that something is better for their patients, so that they get in and offer that for the majority of their phaco glaucoma patients rather than just a subset.
Yeah, I think another example, I guess, for that we mentioned about with interventional glaucoma has been laser trabeculoplasty, which is very much in the center of your work. Yep. And the first line nature of it, and the evidence it's interesting. The evidence for SLT first line is I think I would say is some of the highest level we have, thanks to the work that you've done. What lessons can we learn from that experience in terms of the adoption or the barriers with SLT first line, for example, and how this may parlay into cataract surgery?
That's a good question. I think that I was expecting, once we realized how powerful the results of the trial were at 3 years, both in terms of effectiveness, drop freedom, but also cost effectiveness. So it's a very cost effective treatment because of the prevention of need for additional glaucoma surgery. And in the trial, that was trabeculectomy. I was expecting to be adopted much faster across the board. Now, I'm kind of cynical about some people's motivations in some areas, and not everybody is there writing a business case to get a new laser for their National Health Service hospital. But I was expecting uptake to be even faster than it has been. And it's been a slow burn, particularly in some jurisdictions in some countries. And I think what I take away from that is that people are slow to change. People will see something that's good, but they will be late adopters, perhaps not of skepticism, but because of inertia. And there are a lot of barriers to change. And none of us really like change for its own sake. I think a lot of people have barriers placed in front of them in terms of funding and change to their processes, as you said. I think with interventional glaucoma more generally, and particularly cataract associated procedures, realizing that everyone else around you is doing it and perhaps you're shortchanging your patients, it's quite a big stimulus to getting you to do something. A lot of people now buying lasers and doing lasers and saying, well, it was never really part of my life, my practice, but now I am. I think when you talk to them, they'll often say, well, I now realize that that's become the standard of care. So I think shifting the dial of expectations around those individuals and then helping take themselves through it to adopt something, to realize that the individual steps are not that great, to realize that if they're not currently doing angle surgery, that actually angle surgery can be done safely, that it can be introduced to their practice without a big delay in their surgical list time, without needing to spend a lot of time and complications. And they may remember their glaucoma surgical training or their cataract surgical training, which has a very slow incremental gain of confidence and speed until they're really happy with doing their cataract. Learning phaco takes time. Learning trabeculectomy takes time. And I think a lot of the advantages of modern interventional glaucoma surgery techniques, laser techniques, are that they have a much lower bar to entry.
Yeah, I think you've highlighted, and I tried to study this topic because I'm very curious about adoption and innovation. And of course, in the business world, this has been written tremendously, And I think that the only things I would share to that, add to what you said, is that I think, when I talk to my colleagues, there's a few things that are kind of under the surface. And I think one of them is responsibility and confidence, And I think that when a surgeon performs a procedure and let's say it fails, for example, or it's not predictable, or there's a complication, God forbid, that responsibility really falls on that surgeon, right? You bear that responsibility and you're fearful of that. Giving drops to a patient, over time, and there's a failure or someone progresses, the surgeon, at least I think the ophthalmologist, probably doesn't feel that burden on their shoulder. I mean, we should maybe, because it's our patient, we should. But we don't, you know what I mean? We don't bear the personal feeling of responsibility for that. It wasn't something from our hands, we created a problem, or we failed in what we told my patient. I'm going to do this for you. So I think that responsibility and that confidence and that predictability gap exists. And I think we have to do something about that. We need to improve the confidence of surgeons. We need to provide a rationale that justifies why we do what we do, providing cover, let's say, so to speak, not in a legal sense, but even in a medical sense, and help us understand how to improve the predictability for the right patients and to achieve the highest outcomes. And I think that those are things that hopefully can help. It's the same thing with refractive outcomes in IOLs and toric lenses. Why do surgeons not use toric lenses all the time? Because predictability can be a problem and patients expect there to be a certain delivery. So I think that's part of perhaps some of the challenges. But what do you think, Gus?
No, I think you're quite right. I think it's about that fear of causing harm. If we give someone drops and they get a side effect, or your beta blocker, God forbid, makes them impotent or gives them asthma, well, hey, you blame the drug, you don't blame yourself. And actually the patient blames the drug, they don't blame you. Mm-hmm. But if you find yourself fishing a widget out of the suprachoroidal space because they're hypotenuse, then you blame yourself as a good surgeon. And also so does the patient. So there's there's a two-way sense of guilt and responsibility. And therefore, I think the big change in interventional glaucoma has been that there's an adoption of procedures and processes and lasers that are much, much safer than previously. So I think we've seen around us minimally invasive glaucoma surgeries being adopted at a very fast rate that are very safe. They may not necessarily justify the cost for the amount of pressure lowering that they have, but the rapid adoption has generally, as far as I can see it, been closely linked to those procedures that are very safe. So procedures that are safe as well as easy to use, and they're almost hand in hand, but not necessarily so, tend to be the ones that people adopt early. And then they can then move from there to something where it's perhaps a little bit more difficult to learn. And I think that's interesting, but I think you've hit the nail on the head with the difference in the way in which not just patients, but surgeons perceive the responsibility for causing harm.
And I think the good news is I think we're seeing an evolution of technologies and also just selecting patients the right way and managing patients intraoperatively and training, which I hope will change that dynamic a little bit. But I think that's probably part of it. It's interesting. SLT, I believe has shown such a great track record for safety and is technically, I think, a more predictable procedure even than surgery. But I think we're seeing this changing as well. So I think those are some of the things to consider. But it is good to consider all these aspects, which I think we've highlighted, reasonably well. And I think that we also have to be careful. I think I just have one more comment on this is that part of some of the hesitancy is we've seen some of these technologies used inappropriately. And it's obviously some of the bad apples sometimes that we hear about and it kind of perhaps cast a bit of a larger, shadow on the field. But it is important that we do ensure that we have appropriate utilization of technology. We're using it for the right patient. We are treating glaucoma. I know it sounds obvious. And we're also not using it maybe for patients who need something more aggressive, somebody more advanced who needs a very low pressure, that we shouldn't be fooling around with something that may be light. We need to be going something that's more definitive. So I think that's part of also the right appropriateness of technology utilization that I think is there, and the right training. I think that, those that are embarking on glaucoma therapies, whether they're drops or intervention, need to have the confidence of diagnosis. So we got to go to the basics of this. And we need to follow our patients postoperatively. This isn't a one-shot deal and you're done. This is a need to follow patients for their lifetime and follow them appropriately. So those are the things I think that are also important as we embrace this field, to think about the patient in their entirety.
Yeah, and there are great parallels with adoption of SRT there, because SRT languished being barely used by anyone in this country for two good reasons. One, they were mostly doing it in the wrong patients. So they did in patients, my predecessors were doing SLT or tried to do SLT in patients where it didn't work, and the risk of harm was greater. So they were on patients on multiple medications, the last ditch to prevent surgery, where it really just does not work well at all. Maybe the odd case, but very rarely. And they were much more prone to pressure spikes. So you had the wrong patient selection for a procedure that works very well in other patients. And the light trial is all newly diagnosed patients. And we have analogies there with MIGS, where patient selection is very important, but it's also very important in refining how we respond and think of that particular procedure, that particular technique. And because, one bad case can really put somebody off adopting a technique. And I think it's those individuals that we need to sort of give support to as a profession and help through that initial learning curve, not just to choose the right patient group so they're treating the right patients in the first place, but also to be able to help them adopt technologies that for the best of our patients we need them to adopt, even in the face of the occasional complication, which sadly will come to all of us.
Well, I think this has been a great conversation, Gus. You always enjoy the discussions that you learn from the person you're talking to, but also that person brings out ideas yourself from your own self. And I think you've done that for me as well. So, you're bringing ideas that I just think about talking to you because you've simulated something. And I hope that's done that for our listeners as well. I'm looking forward to our next podcast. I know that we are hoping to really address and dive deeper on some of the things we've mentioned here today. Talking about what's happening, what's new, what some of the challenges are, educational topics, and just having, like we have today, fairly unscripted chats that can go in any direction. And by the way, I won't tell anyone what you're wearing for this conversation, because this is a podcast, so you're lucky today. But I wonder if you want to just talk about some teasers about some future topics, just to kind of finish up this podcast. And again, it's been a real pleasure to chat with you here today.
No, it's been great, and I'm looking forward to what we've got coming. We've got some topics where myths and misconceptions around the trabecular meshwork, anatomy, physiology, function, some of the finer points of the new science and new developments that have been coming out over the last few years, because there's still been a lot of basic science work that I think really feeds nicely into a lot of the IG framework and the MIG space. I think thinking about aqueous flow and controls and mechanisms around aqueous flow really will deserve some thought and some decent discussion. And then obviously some of the more really practical things around this space, which is patient selection. Who do we choose for, whether it's a laser sclerostomy or a device implantation, whatever, who do we choose to carry that out on? What do we need to tell the patients, and how we manage those kind of post-op pearls? So that's another separate topic that I think we'll bundle up together and will be really nice to go into in some depth. So that's what I'm looking forward to particularly.
Yeah, I think I'm excited for this, and we hope to cover some zoomed out topics like we've done today, and zoom in on certain topics and even technologies that are coming on the forefront as well. So I think that's what we'll do. And by the way, just my previous comment, Gus is wearing a shirt. It's just a very bright shirt today. You can imagine that. So, well, listen, it's been great, Gus. We will talk again, and thanks again for a great chat. And we look forward to all of you tuning in to our next podcast. So stay in touch.
Thank you for tuning into this episode of Interventional Glaucoma. Want to hear more? Be sure to click the subscribe button to be notified of new episodes. For more information about this episode's topic, read the show notes at eliosvision.com/OUS/podcast. Elios Vision GmbH is the EU distributor of Elios, manufactured by Emlaze GmbH, and the FIDO laser applicator, manufactured by Vinert Fiber Optics GmbH. Elios is CE marked and licensed for use in the EU and is currently under investigational use in the US. Please refer to the full disclaimer in the show notes.